అంటారు కదా.
Good evening, everyone. I'm Dr. Rohit, and today we'll be discussing the general medicine questions. So, let us start right away with the first question. First question was asked was obesity, definition, etiology, complications, and management. So, uh, in this session, I will not be going into the depth of the topics, but I think I'll give you an outlook, a framework where you can frame the answers so that you can score the maximum. Because you have all the literature available with you. I suggest you go through the videos and the content also, if required. I'll mainly be giving you an overview of how to approach this answer. And if you have any doubts, you can go back to the content. And during the session also, if you have any doubts, please feel free to ask, post them, so that at the end of my topic, I'll clarify your doubts. Okay, so let's start with obesity. So how do we define obesity? Biologically, it is a state of excess adipose tissue mass in the body. So that is the biological definition. But for epidemiological purposes or for all practical purposes, how do we define obesity is based on body mass index. What is body mass index? It is nothing but an individual's weight in kilograms divided by height in meters square. So that's how we calculate body mass index. And if the body mass index is less than 18.5, we call these individuals underweight. And if somebody's BMI falls between 18.5 to 24.9, we call them healthy individuals, that is healthy weight. If the BMI falls between 25 and 29.9, that is where we call them overweight. If the BMI exceeds 30, that is with between 30 to 34.9, it is called class 1 obesity. If the BMI is 35 to 39.9, it is called class 2 obesity. And if it is more than 40, we call it class 3 or sometimes extreme or morbid obesity. In addition to body mass index, there is one more marker, one more measure we use, which is the waist circumference. Some studies use waist circumference also to assess the risk of obesity. So the waist is measured just above the iliac crest. It is a surrogate marker of the visceral fat inside the body. So for Indians or Asians for that matter, the waist circumference, if men have a waist circumference of more than 90 centimeters or 35 inches, they are called obese. Or if women have more than 80 centimeters or 31.5 inches of waist circumference, they fall under the category of obesity. So when we define obesity, biologically it is state of excess adipose tissue mass. And when we have to objectively define obesity, we do it by using these two indices. One is body mass index and the other is waist circumference. In body mass index, you have categories like underweight, healthy, overweight, class 1 obesity, class 2 obesity, and class 3 obesity. These are all based on WHO definitions. And waist circumference, for men, it is more than 90 centimeters. For women, it is more than 80 centimeters. Coming to the etiology, the basic cause of obesity is the main mechanism, underlying mechanism for obesity is long-term energy imbalance between consumed calories and expended calories. When the consumed calories become more than the expended calories, this over a period of time, this leads to obesity. What are the individual causes? See, the individual causes can fall into various categories. The first being behavioral factors. So, behavioral factors include obesogenic foods. So, having high calorie foods, foods rich in fats, so that leads to obesity. Another behavioral factor is physical activity patterns, that is, sedentary lifestyle, lack of physical exercise, and all these things include the behavioral factors. After behavioral factors, let's look at some endocrine disorders. Endocrine factors which lead to obesity. They are polycystic ovarian syndrome, diseases like hypothyroidism, Cushing syndrome, and hypothalamic diseases. After endocrine disorders, some drugs also are known to cause obesity. Anti-diabetic medication like insulin, sulfonylureas, and thiazolidinediones are the drugs which can lead to obesity. Some antidepressants like tricyclic antidepressants or SSRIs, selective serotonin reuptake inhibitors, these also can cause obesity. And mood stabilizers like lithium is known to cause obesity. Steroids can lead to obesity, and certain anti-epileptic drugs like anti-seizure medication like valproic acid, carbamazepine, or gabapentin also can lead to obesity. There are certain genetic factors which can also cause obesity. Uh, you can categorize them into monogenic, syndromic, and polygenic genetic factors. The monogenic genetic factors are AGRP gene, orexin gene, or melanocortin receptor gene mutations. So these gene mutations can lead to obesity. When you come to syndromic category of genetic factors, syndromes like Prader-Willi syndrome or VAGR syndrome or Smith-Magen syndrome, these individuals are also prone to developing obesity. When you look at polygenic, it could be multiple genes. So in these patients, obesity runs in their families. So after discussing etiology, let us come to complications. What are the complications of obesity? Diseases like diabetes, hypertension, dyslipidemia, which is abnormal, like abnormal fats basically. The lipid profile is deranged in them. So LDL, elevated low density lipoproteins, elevated VLDL, elevated triglycerides, all these things are a result of obesity. It can also lead to coronary heart disease. It can lead to heart failure. In brain, it can lead to stroke, vascular dementia. When you look at respiratory diseases, obesity can lead to obstructive sleep apnea syndrome. Coming to gastrointestinal system, it can lead to non-alcoholic fatty liver disease. It can lead to gallbladder diseases. It can lead to pancreatitis. It can lead to infertility. Coming to musculoskeletal complications, obesity can lead to osteoarthritis. It is also known to worsen rheumatoid arthritis and certain psychological conditions like obesity can sometimes worsen depression as well. There are certain cancers which are associated with obesity, especially esophageal cancers, colon cancer, breast cancer, and endometrial cancer. Then comes the management. How do you manage obesity? Whenever there's a question on management, it should include investigations as well as treatment. So in investigations, you do all the complications that we have discussed, you screen for those complications. We'll mainly discuss the treatment part here. Treatment of obesity, it includes 3 steps. One is lifestyle modifications, second is pharmacotherapy, third is surgical therapy. So first, let us discuss lifestyle modifications or lifestyle management. So in lifestyle management, you should emphasize on diet therapy, where you have low calorie diet, low calorie healthy diet to maintain a calorie deficit. Then the next point will be physical activity therapy. So a minimum of 75 to 150 minutes of rigorous activity per week should be for normal individuals. If somebody is obese and is trying to lose weight, they need to create a calorie deficit. They need more physical activity. Then comes behavioral therapy also. Cognitive behavioral therapy and psychological counseling is also known to help people motivate themselves and reduce the risks of obesity. So after lifestyle management comes the pharmacotherapy. So basically pharmacotherapy is nothing but drugs to reduce obesity. These drugs fall into two broad categories. One is appetite suppressants. So obesity is because of excessive eating, right? So these drugs, these class of drugs, they suppress the appetite. Another class of drugs are fat blockers. What they do is when the patient consumes food and fatty foods, they bind to the fatty foods and they make sure that the fat is not absorbed into the blood. So that's how these two category of drugs work. So first, the appetite suppressants. Let us discuss some examples. First category is glucagon-like peptide 1 agonists. These are drugs mainly used for diabetes, also used in obesity. Examples are liraglutide and semaglutide. You might have heard of Ozempic of late. It is nothing but oral semaglutide, which is available even in India. The other drugs are phentermine and topiramate, naltrexone and bupropion, or locarcerin, which is a serotonin receptor agonist. These are appetite suppressants. What are fat blockers? Fat blocker drug is orlistat. Orlistat is a lipase inhibitor. What it does is it does not allow the fatty foods from the intestine to get absorbed into your circulation so that the fat gets passed in the stools. So that is pharmacotherapy. In patients who are in class 3 obesity or class 2 obesity, but who fail pharmacotherapy and lifestyle modifications, in such patients, we go for bariatric surgery. This is the third option for patients with obesity. So in bariatric surgery also, there are two kinds of procedures. One is called the restrictive procedures. The other are called restrictive malabsorptive procedures. So in restrictive procedures, what happens is basically they reduce the size of your stomach. That means ultimately they reduce the amount of food that you can eat at once. So that way your calorie intake comes down. Examples are laparoscopic gastric banding or laparoscopic sleeve gastrectomy. So they remove one part of the stomach so that the individual can eat only a little bit of what they used to eat earlier. The second category is restrictive malabsorptive procedures. Basically, these are bypass procedures. Examples are Roe-en-Y gastric bypass, biliopancreatic diversion, or biliopancreatic diversion with duodenal switch. So this is how you need to answer when you have a question on obesity. So now let's discuss the second question, the part B in the first question, anemia. So what is anemia? How do we define it? Anemia is a hematological condition where the number of red blood cells or the hemoglobin concentration in the red blood cells is low. Excuse me. So anemia is hematological condition where number of red blood cells are low or the hemoglobin concentration in these red blood cells is low. So objectively, anemia can be defined based on hemoglobin levels in the blood. So WHO has defined anemia in 2024. This is again different for males and females. In males, if the hemoglobin is less than 13.5 grams per deciliter, we can label them as anemic. Or if the hematocrit is less than 40%, they can be called anemic. In females, we can diagnose anemia when hemoglobin is less than 11.5 grams per deciliter and hematocrit is less than 35%. So in males, it is hemoglobin 13.5 or less and hematocrit less than 40%. In females, it is hemoglobin less than 11.5 and hematocrit less than 35%. Once we have defined anemia, let us move to etiology. See, etiology of anemia can be, we can actually discuss the causes of anemia in various fashions. So one way of classifying anemias is basically based on the pathophysiological mechanisms. So for an individual to have a good circulatory system and with all normal parameters, they need to have adequate erythropoietin production. They need to have good iron availability. They need to have good proliferative capacity of the bone marrow. They need to have effective maturation of red blood cell precursors. And then there should not be any loss or destruction of the red blood cells that are already there in the circulation. So these are the basic mechanisms. 1, erythropoietin production. 2, iron availability. 3, proliferative capacity of the bone marrow. 4, effective maturation of red blood cell precursors. 5 is basically no loss or destruction of red blood cells which are already there in the circulation. So based on this, we can classify anemias as hypoproliferative anemias. So in hypoproliferative anemias, basically there is less production of red blood cells or their red blood cell precursors. So examples are chronic kidney disease, chronic liver disease. This happens because, see, erythropoietin is the protein which is required for hematopoiesis, that is RBC production. So erythropoietin originates in, or it is there in the liver and kidneys. So whenever there is chronic kidney disease or chronic liver disease, it can lead to hypoproliferative anemia. Sometimes anemia of chronic disease also can be there. Iron deficiency anemia, aplastic anemia, multiple myeloma, vitamin B12 deficiency and or folate deficiency anemias also can lead to hypoproliferative anemias. Then anemia due to maturation defects. So when the progenitors of red blood cells, which are there in the bone marrow, they are not able to mature in a healthy way. That is when you have maturation defects. So what are the causes of maturation disorders? Again, vitamin B12 deficiency, folate deficiency, iron deficiency, and myelodysplastic syndromes, sideroblastic anemia. Sometimes certain drugs also can cause maturation defects like methotrexate and alcohol. The next mechanism of developing anemia is blood loss. Blood loss can be acute. For example, whenever an individual has a head injury, or for example has an external injury and blood loss, or a patient has undergone surgery and there is blood loss, or pregnant women during delivery have blood loss, that can lead to acute anemia. Blood loss can also lead to chronic anemia sometimes. So this happens in peptic ulcer disease when there is slow or gradual loss of blood in the GI tract. So the fourth and last category of anemia, causes of anemia, is hemolytic anemia. Hemolytic anemia, basically the hemolysis. There is destruction of the blood cells, red blood cells, which are there in the circulation. This hemolysis can happen in the blood vessels, which is known as intravascular hemolysis, or it can happen outside the blood vessels, that is in organs like spleen. So which is known as extravascular hemolysis. So examples of intravascular hemolysis are sorry, paroxysmal nocturnal hemoglobinuria, paroxysmal cold hemoglobinuria, microangiopathy, ABO mismatch, or snakebite. Examples of extravascular hemolysis are sickle cell disease, thalassemia, hereditary spherocytosis, G6PD deficiency, immune-mediated hemolytic anemia, liver disease, and splenic disease like splenomegaly. So this concludes the causes of anemia. So causes of anemia can be discussed under the following headings: hypoproliferative anemias, maturation disorders, blood loss, and hemolytic anemia. Coming to complications. Complications of anemia could be, they range from simple clinical manifestations, simple symptoms, to life-threatening symptoms. So simple symptoms like malaise, easy fatigability, or unusual tiredness can be the symptoms. Anemic patients can sometimes have frequent headaches and dizziness. They can have mental clouding, especially in B12 deficiency, or it can sometimes lead to a neurological disease called restless leg syndrome. When anemia is severe, or when it is there for a long time, it can lead to end organ damage as well. That way, it can lead to heart failure, ischemic heart disease, and in lungs, kidneys, and liver also, it can lead to serious disorders. Anemia can complicate pregnancies. There may be complications during childbirth. And in children, anemia can lead to growth retardation and developmental delay. There can be increased risk of infections. And sometimes anemia can also cause depression and other behavioral changes like pica. Pica is nothing but, individuals, children especially, they have a tendency to eat non-edible items like soil and chalk pieces and all that. So that is called pica. That's also a symptom of anemia. So these are all the potential complications of anemia if it worsens and if it is not treated at the right time. So coming to management of anemia. So management, as I said earlier, should always include investigations and treatment. So what are the investigations that you do in a patient with anemia? First thing is we do their complete blood counts, which is we also call it CBP. So in that we look for hemoglobin, we look for hematocrit, we look for their reticulocyte count, and then we look at the red blood cell indices of them, like mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration, then red cell distribution width. And we also look at white blood cell parameters like total WBC count and nuclear segmentation of these neutrophils and differential white blood cell count. We also look at their platelet counts, and the cell morphology also has to be studied, like cell size, hemoglobin content, if there is any anisocytosis, that is uh, red blood cells of different shapes, different sizes, and polychromasia, the difference in content of hemoglobin in RBCs. The next level of tests are iron studies, serum iron studies like total serum iron, total iron binding capacity, or serum ferritin. And in advanced cases or serious disorders, sometimes we may also need to do a bone marrow examination. So bone marrow aspiration is done, and there are certain indices that we need to look into, like myeloid erythroid ratio, cell morphology, iron staining, and in biopsy, we also look at the cellularity and morphology. So depending on all these investigations, we try to classify which type of anemia and diagnose the anemia so that we come to the treatment part, because treatment of different causes of anemia will be different. So let's say, for example, if it is anemia of chronic disease, then we need to treat the underlying disease. If the problem is diabetes, if the problem is CKD, if the problem is chronic liver disease, we need to treat the primary disease first. Or if there is any deficiency in certain elements like iron deficiency or B12 deficiency, in such cases, we need to supplement iron. Iron can be given orally or parenterally. Vitamin B12 is usually given parenterally. And if the anemia is severe, we may have to do transfusion of blood components like whole blood transfusions or packed cell transfusions. And in certain diseases like thalassemia, we may have to do iron chelation therapy. In chronic kidney disease where erythropoietin is deficient, we give these patients erythropoietin injections, recombinant erythropoietin injections every week. And in certain conditions like sickle cell disease and thalassemia, targeted gene therapy is also under studies. Near future, we may have this as uh, a therapeutic option in cases of certain diseases like thalassemia. And in, for example, if it is a case of aplastic anemia, in such conditions, we may have to go for bone marrow transplantation as well. So with this, we conclude the, the long answers. Anemia also we have covered. Next, let us come to the short notes. First one being causes of ischemic heart disease. So causes of ischemic heart disease can be classified into non-modifiable, modifiable. So in modifiable, we have modifiable medical factors and modifiable lifestyle factors. So what are the non-modifiable causes? One is age. Advancing age is a risk factor for ischemic heart disease. Second is gender. Males are more prone to developing ischemic heart disease. And family history. If an individual has a family history, if people in his family have the history of ischemic heart disease, they are also prone to developing it. Then coming to modifiable medical factors. What are the modifiable medical factors? They are hypertension, diabetes or hyperglycemia without over diabetes, dyslipidemia, chronic kidney disease, HIV infection, and inflammatory conditions like high CRP, IL-6, and MPO. And then sometimes mediastinal radiation. Patients who undergo radiotherapy for some other disease, they also can develop ischemic heart disease. So hypertension, diabetes, dyslipidemia, chronic kidney disease, HIV infection, and mediastinal radiation. What are the modifiable lifestyle causes? Modifiable lifestyle causes are smoking. We need to avoid smoking to develop to prevent ischemic heart disease. Then there has to be healthy balanced diet. Lack of exercise is a risk factor for ischemic heart disease. Alcohol consumption, obesity, and psychological stress. These are modifiable lifestyle causes of ischemic heart disease. Smoking, diet, lack of exercise, alcohol, obesity, and psychological stress. So when we talk of cause, we may have to add 1 or 2 points on the pathophysiology also. So the pathophysiology of ischemic heart disease includes coronary atherosclerosis, where there is endothelial dysfunction, inflammation, there is plaque formation within the blood vessels, and when the plaque ruptures, this leads to acute myocardial infarction. Sometimes hypertrophy of cardiac muscle, which we see in long-standing hypertensive patients, also can lead to increase in demand of oxygen, and then that can lead to ischemic heart disease. So that should be adequate for discussion of causes of ischemic heart disease. Coming to treatment of diabetes mellitus. So there are various stages of treatment of diabetes mellitus. One is medical nutrition therapy. In mild cases, we can just try a low calorie diet and a medical nutrition therapy to manage diabetes. The next component will be weight management. Weight management can be done by diet, drugs, or even by surgery. So maintaining healthy weight can also reduce the blood sugar levels. And having regular exercises, making certain lifestyle modifications like avoiding sedentary behavior, avoiding late awakening during late nights, and then avoiding junk foods or highly saturated fatty foods that can prevent diabetes. And the last will be psychotherapy. So psychotherapy and counseling also helps patients in treatment of diabetes. When all these things fail, we have to resort to medicines. So what are the medication that are available for treatment of diabetes? So I'll discuss them in various categories. The first category is alpha glucosidase inhibitors. So alpha glucosidase inhibitors, they act on the intestine. What they do is they slow the carbohydrate digestion. So they prevent the glucose spike from happening in the blood. So alpha glucosidase inhibitors, example is voglibose. The other category of drugs are GLP-1 receptor agonist, glucagon-like peptide receptor agonist. They work on brain as well as pancreas. What they do is they enhance the incretin effect. So the incretin effect is increased, and that's how they reduce the blood sugar levels. Similarly, the next category are DPP-4 inhibitors. They also act on the brain and pancreas. They also enhance the incretin effect. The next category are, these are old drugs. They are known as sulfonylureas. Sulfonylureas act only on the pancreas, and they squeeze the pancreatic cells. They squeeze insulin out of the pancreatic cells. So they stimulate insulin secretion. Examples are glimepiride, gliclazide, glibenclamide. These are examples of sulfonylureas. The earlier category examples of GLP-1 agonists are the GLP-1 agonists, which they enhance the incretin effect, and the DPP-4 inhibitors, they also enhance the incretin effect. DPP-4 examples are sitagliptin, vildagliptin, and GLP-1 receptor agonists are, they are basically injectable drugs which are not very often used. That too, especially in India, they are not very often used. Examples are repaglinide. The next category is meglitinides. They also squeeze insulin out of pancreas. They stimulate insulin secretion. Examples are pioglitazone. The next category is biguanides or metformin. So metformin, it acts on the liver. It reduces glucose production. It increases glucose use, and it counters the insulin resistance. The next drugs are thiazolidinediones. These drugs increase the insulin sensitivity. And SGLT2 inhibitors are new drugs, which are the examples are empagliflozin and dapagliflozin. What they do is they increase the excretion of glucose through urine. So they are called glucosuric drugs. So they act basically on the kidneys. in type 1 diabetes patients and in type 2 diabetes patients who are in whom the oral medication are not effective, we go for insulin injections. Insulin can be short acting or long acting also. So insulin it increases glucose uptake, it decreases storage, then increases the metabolism, and it suppresses the glucose production. So these are the broad categories of medicines that can be used for treatment of diabetes. Alpha glucosidase inhibitors like voglibose, GLP-1 receptor agonists, DPP-4 inhibitors, sulfonylureas, meglitinides, metformin, thiazolidinediones, SGLT2 inhibitors, and insulin. Let's move to the brief notes now. The first is barrel-shaped chest. How do you define barrel-shaped chest? Barrel-shaped chest is abnormally rounded chest. Usually the chest has to be, the transverse diameter has to be more than the anteroposterior.
So sorry to interrupt. Can you please change the slide according to the discussion?
Yeah. Okay. So usually normally the shape of the chest is elliptical. That is, the transverse proportion is more than the anteroposterior proportion. But when the chest is abnormally rounded, it is called barrel-shaped chest. So when the anteroposterior diameter is almost as equal as transverse diameter, where the ratio reaches nears 1:1, then it is defined as barrel-shaped chest. What are the causes of barrel-shaped chest? Common chronic respiratory conditions most commonly which cause barrel-shaped chest are COPD and emphysema, chronic obstructive pulmonary disease and emphysema. Another respiratory disease called cystic fibrosis also can lead to barrel-shaped chest. Other rare causes of barrel-shaped chest are osteoarthritis and acromegaly. So how do you manage this condition? Basically, you treat the underlying disease. That's all. This is not a condition. This is the clinical finding, which is a result of the underlying disease. So let's move on to the next question, which is causes of chronic kidney disease. Causes of chronic kidney disease could be poorly controlled diabetes. The most common cause of kidney disease in adults in India or worldwide is poorly controlled diabetes. Another cause is hypertension. Poorly controlled hypertension is a risk factor, or long-standing hypertension is a risk factor for developing chronic kidney disease. Other conditions like glomerulonephritis. Glomerulonephritis can be secondary to infection or it could be immune mediated. Whatever the mechanism be, glomerulonephritis can lead to chronic kidney disease. Another genetic condition which leads to chronic kidney disease is polycystic kidney disease. We have an autosomal dominant type and an autosomal recessive type in this. ADPKD is the dominant type, ARPKD is the recessive type. So polycystic kidney disease is another cause. Heart failure. In patients with heart failure, there is a condition called cardiorenal syndrome which develops over time. So cardiorenal syndrome can lead to chronic kidney disease. Then hepatorenal syndrome, which is seen in chronic liver diseases. So individuals suffering with liver diseases can go on to develop renal dysfunction also. Certain environmental factors like lead exposure to lead, people working in certain factories and industries can also develop chronic kidney disease. Smoking can worsen kidney disease. Obesity can also lead to kidney disease. Certain drugs like NSAIDs and some antimicrobial drugs which are nephrotoxic, for example, amikacin. So drugs like this can also lead to chronic kidney disease. The next question is treatment of bronchial asthma. So how do you treat patients with bronchial asthma? The first and the easiest way is to control the triggers. Asthma patients have multiple triggers. Some get triggered by pollen, some get triggered by dust, some get triggered with cold weather, or some can get triggered with some food items also. So we need to identify the triggers in that particular individual and control the triggers. After that, we'll discuss the drugs that are used. The first category of drugs are short-acting beta agonists. These are, they act for a short time. These can be given orally as well as inhalationally. So the drugs of choice are inhalational beta agonists. So we have short-acting beta agonists as well as long-acting beta agonists. Long-acting beta agonists are more preferable because of their good pharmacological profile. So short-acting examples are albuterol and salbutamol. Long-acting example is formoterol. The next category of drugs are glucocorticoids. Glucocorticoids are considered as disease-modifying agents in when it comes to asthma. So they can be oral or systemic or inhalational. So oral or systemic glucocorticoids are prednisolone or hydrocortisone. Inhaled glucocorticoids are basically beclomethasone, budesonide, fluticasone, or mometasone. The next category of drugs are leukotriene antagonists. Example is montelukast. They basically reduce the inflammation and the tendency to initiate uh, the basically inflammation which sets in the bronchioli. Newly developed monoclonal antibodies, anti-IgE monoclonal antibody, omalizumab. Subcutaneous injections of omalizumab are also used in severe asthmatic patients. So in them, these are the drug options that are available for us, and we can adopt a step-up approach. So in mild cases, there is something called step 1, where we give them only short acting beta agonists whenever required. Whenever they have breathlessness, they just take an inhaler. That's all. In step 2, we give them beta agonist, inhalational beta agonist, along with low dose inhalational corticosteroid. In step 3, we give them inhalational corticosteroid plus long acting beta agonist like formoterol. In step 4, we ask the individuals to take prophylactic, that is everyday inhalational long-acting beta agonist and inhalational corticosteroid also. In these patients, we can also add leukotriene antagonists like montelukast. In step 5, we have to use high-dose inhalational corticosteroids, long-acting beta agonists, and sometimes we may have to use other drugs like omalizumab, the IgE monoclonal antibody. Step 6, we may have to use systemic corticosteroids also. Sometimes we may have to use oral steroids or injectable steroids. For example, when a patient with acute asthma exacerbation comes to us, we might have to give them IV hydrocortisone also, in addition to inhalational beta agonists. So I think that come to the end of my set of questions that were given to me. If there are any doubts, please feel free to ask.
No questions have been asked, sir. You can end the session.
Okay.
Thank you.
Thank you.
Hello.
Yes, sir.
Yeah, is my screen visible?
Yes, sir. I can't see the PPT yet.
Wait for a sec. Yeah. Now is it fine?
Yeah.
So can am I visible?
No, sir.
How do I do it then?
Yeah, now you're visible.
Next second. Yeah. Now I'm visible,
Yes, sir.
but the screen is showing double thing, right? I mean, the screen is clear,
Yes, sir. I can see the PPT and you as well.
right? So should I start up the video?
Yes, sir.
Right. Hello everyone, I am Dr. Vishnu Soni, General Surgery Faculty for Prakara. I am doing my assistant professor in Government Medical College, Sangareddy. Today we are here to discuss exam preparation session for general surgery. These were the questions, and now we'll discuss one by one. And I would just give you tips and tricks to easily write the questions and get good marks. Right. So first question is classify burns and depth and surface area. Discuss plastic surgical procedure in management of burns. Right. So before attempting any question, what do you have to remember is you should write the definitions first. Be it whether he has asked or not, you should write the definition first. So right. So what will be the definition of burn? Burn is injury to skin and the deeper tissues due to any external source of energy. That can be thermal burn, that is heat, cold, that can be electrical. So radiation, it can be radiation also. So these are the different kinds of different energies which can cause burn. So you should write the burn definition first. Right. So whether he has asked in the question or not, you should write definitions first. So after writing Burns definition, you will classify burns. Burns is classified into degrees, 4 degrees: first degree, second degree, third degree, and fourth degree, based on depth and surface area involved. So first degree burn is injury or burn affected only to the epidermis part of the skin. Second degree is epidermis and part of the dermis. Second degree is again divided into superficial and deep. Superficial second degree is it is affecting only papillary dermis, and second degree deep is it is affecting papillary plus reticular dermis. Third degree is it involves skin, subcutaneous tissue, that is epidermis, dermis, and part of the subcutaneous tissue is third degree burn. Fourth degree is it involves bones and tendon also, skin, subcutaneous, and the deeper organs like bones, tendons are also involved in fourth degree burn. Fourth degree is it involves all the layers of skin and deeper tissues. Okay, so in first degree, the treatment or the wound looks like green color. In second degree, it will have blisters. Third degree, it is charred out. Fourth degree is also charred out. So this is how you divide or you classify burns. Should I continue?
Yes, sir.
Yeah, thank you. So these are this is how you divide or you classify burns based on depth and surface area. After that, the next part of the question is discuss plastic surgical procedure in management of burns. So plastic surgery involving burns is very common nowadays because the more evolvement of surgery, patient needs good cosmetic clearance and good psychological or functional mobility is also required these days. So plastic surgery involvement in burns is much more required now. So first thing, what do you write is importance of plastic surgery in burns. To elaborate the answer or to describe more about the plastic surgery, you should initially start with importance of plastic surgery. Then what are the different procedures? First one is excision, or you can call it as debridement also. Right. So what do we do here is it is excision and suturing is useful in small scars where the scar is excised and sutured. So first one is excision. Second one, skin grafting. Grafting is it's most commonly used plastic surgery module in burns cases. Skin grafting are different types, such as first one is split skin grafting. In split skin graft, only the superficial part of the dermis is involved or removed from donor site and placed on recipient site. That is split skin grafting. Full thickness or partial thickness is you involve in second type is partial thickness. In partial thickness, you involve epidermis and part of the dermis. is partial thickness. Full thickness is epidermis, dermis, and subcutaneous part is also involved. So these are the three types of skin grafting: split skin grafting, partial thickness, and full thickness grafting. Then what are the reconstructive procedures? The reconstructive procedures are, you can use different grafts. They are called as pedicle graft. In pedicle graft, skin, subcutaneous tissue, and also skin and subcutaneous tissue are removed from donor side and placed on the recipient side. So the whole bulk of the tissue is removed from one side and placed on other recipient side where the burns have occurred. So that is one type of reconstruction that are called as pedicle graft. Other reconstructive procedures are, you use dermal substitutes. Skin substitutes are three types: skin substitutes, epidermal substitutes, dermal substitutes, and epidermodermal substitutes. These are the three skin substitutes. So what are these substitutes? See, in epidermal substitute, you take a part of the epidermis from any cadaver or any other person and grow in laboratory. That will form as sheet. This sheet is placed in the recipient site, in recipient patient or in burns patient, that is epidermal. Dermal substitutes are directly placed on the dermal things, are keratinocytes are taken from the same patient and placed on the wound. That will form as dermal substitutes. That will grow as sheet. So that is dermal substitute. Epidermodermal substitute is, it will have both epidermis part and dermis part, and this is directly placed on the recipient side. The disadvantage with dermal substitute is an stage procedure. After placing dermal substitute, you should clear or you should close the dermis with split skin graft. Again, the second procedure will be done, that is split skin grafting should be done for dermal substitutes. So these are reconstructive procedures. So to elaborate or to quickly again revise what are the reconstructive procedure. First one is, I said, flap, pedicle grafts. Second one is flap. What is the difference between pedicle graft and flap? Is pedicle graft, you take only the skin, subcutaneous tissue from donor side and place it on the recipient side. There is no intact blood supply for pedicle grafts. Always remember, graft will not have its own blood supply. Graft will depend on the blood supply from the recipient side. So that is pedicle graft. Now second, next one is flap. Flap is nothing but it will have skin, subcutaneous tissue, sometimes muscles also, where they have their own blood supply. That is flap. Third one is, in reconstructive procedures, other one is dermal substitutes, and last one is surgeries. Z technique, VY plastics. These plastic techniques are done to excise scars. So these are the different plastic procedures involved in management of burns. That is how you elaborate the answer. First, list out or remember the side headings of what all you will write, and from there you can simply keep the side headings and elaborate on each one. In this way, if you present the answer, you will score more. Next question is colostomy. Yeah, colostomy. Stoma is nothing but you open or you incise abdominal wall and bring out the intestine out. So stoma can be ileostomy or colostomy. Ileostomy is ileum, that is small intestine is brought out, and colostomy is large intestine is brought out in colostomy. Colon is brought out. So stoma is nothing but an opening in the anterior abdominal wall through which the intestines are brought out. So colostomy is a surgical procedure that brings one end of the large intestine out through the abdominal wall. During this procedure, one end of the colon is diverted through an incision in the abdominal wall to create a stoma. Yes, so colostomy can be three types. That is, three parts of colon can be brought out. One is ascending colon, that is ascending colostomy, that is ascending colon is brought out. Then transverse colostomy, transverse colon is brought out. Descending colostomy, descending colon is brought out, and sigmoid colostomy, where sigmoid colon is brought out. It is of four types. Now, describing the types of colostomy. Types of colostomy, first one is end colostomy. End colostomy is done in tumors, large intestine cancers, where the distal part of the colon is sutured or closed permanently. That is, Hartmann procedure is done, and the proximal part of the intestine is brought out. That is end colostomy. Second one is double barrel colostomy. in double barrel colostomy, both proximal and distal part are brought out. From distal part, the mucus comes out, and from the proximal part, stool comes out. So these are the two types: end colostomy and double barrel colostomy. And what are the complications of colostomy? Then see, what is the use of colostomy? To bring the stool out. After bringing the stool out, there is a bag on the colostoma where the stools are getting collected. Due to the stool, there can be infections, redness of the skin. There can be sometimes due to this opening on the anterior abdominal wall, herniation can be there. From other part of the bowel can come out. These are some of the complications of colostomy. So remember, whether it is short note or long note, describe everything little. Even if you describe little about everything, you will score more marks. Keep the side headings and describe things. So yes, colostomy, all about colostomy is this. Next question is abdominal incision. Abdominal incisions, yes, there are different types of abdominal incisions. I have said in my, I have elaborated very detailedly in my surgical class. So what are the different types of abdominal incisions and why do we use abdominal incision? Abdominal incisions are used to open up the abdomen and to treat the organs like stomach, esophagus, spleen, liver, large intestine, small intestines. They can be all assessed through abdominal incisions. Okay, so why do you have to assess abdominal incisions? Because there can be infections, there can be tumors, there can be cancer, there can be trauma, there can be bleeding. All these are the reasons to open up the abdomen. So what are the different types of abdominal incisions? One is midline incision, which where you open it. This is an universal incision where you open this from xiphisternum to lower part of the umbilicus up to pubic symphysis. This is then midline incision, right? So other is paramidline incision, paramedian incision, which is given lateral to the midline. Next, other thing is Cocker's incision. Cocker's incision is nothing but two finger beds below to the rib, subcostal part, two finger beds below the subcostal part where you incise the skin. That is Cocker's incision. Cocker's incision is used in liver to evaluate about liver and gallbladder. Sometimes stomach also. Other incision is chevron incision, where you give both sides subcostal incision, or Cocker's incision on the both side is nothing but rooftop or chevron incision. Other next incision is Mercedes-Benz incision, where it is an extension of a rooftop or chevron incision, where it is extended onto the thorax. This is Mercedes-Benz incision. Other incisions are gridiron incision, Lance incision, which are used for appendix. Gridiron incision is nothing but McBurney's point, perpendicular to the McBurney's point, and longitudinal vertical incision is given on McBurney's point, perpendicular to it. So that incision is gridiron incision, and that is used in appendicectomy surgeries in acute appendicitis. So these are different types of other incisions are transverse incision, which are given above the umbilicus transversely. It is used in pediatric cases. Another is fan and steel incision, which is used in LSCS. Cesarean sections, they use fan and steel incision, which is given on lower abdomen, 2 centimeters above to the pubic symphysis. It is given transversely. So these are different types of abdominal incision. Remember, I am repeating again, you need to write the different side headings, different incision side headings, and you should write 2 points in it. You will score good marks. Next one is complications of cholecystectomy. Yeah, cholecystectomy is nothing but excision of gallbladder. Why do you have to do excision of gallbladder? It is done in multiple gallbladder stones. If the patient has multiple gallbladder stones, then cholecystectomy is performed. Other reasons can be gallbladder polyp. Polyp more than 2 centimeters will have to excise the gallbladder. So cholecystectomy can be done in two ways, open and lap. We are discussing here about open cholecystectomy complications. Complications as such of any surgery complications. First complication you should write as bleeding. That is because you are opening up the organ, opening up the skin and deeper tissues, there is always a risk of bleeding. Yes, so first you can write in blindly, you can write in any surgery complications. First one is bleeding. Next one is infections. Yes, because you are exposing the inner environment to the outer environment, there is always a chance of infection. So second complication is infection. Third, bile leakage. Yes, you are suturing or you are ligating cystic duct. Sometimes that ligation can slip off. That stapler can slip off from CBD or not cystic duct. Then there can be bile leakage. There is a chance or a dangerous complication of cholecystectomy is injury to CBD. Yeah, injury to bile duct is one of the major complications where the patient lands up in deep trouble whenever cholecystectomy patient lands up in bile duct injury. Next, there can be pancreatitis. Yes, sometimes stones can slip off in the CBD and obstruct pancreatitis, causing pancreatitis. These are complications of cholecystectomy. Next question is post-operative complications of thoracotomy patient. Yes, thoracotomy patient, pneumonia, a respiratory infection is more common post-op complication of thoracotomy. Atelectasis, a collapse in one or more areas of your lung. Yes, atelectasis due to thoracotomy incision. What happens is patient is unable to breathe. Why? Because he'll have pain. Your thorax muscles, your intercostal muscles are helping in respiration. And due to this incision or due to this surgery, the patient is unable to breathe. And when he is unable to breathe, what happens? The part of lung will not function and that will go into collapse. That is called as atelectasis. Next one is pain. And as I said, any complication, any surgery, you can write it as first as bleeding and then infection. So this is how you write a question of complication of thoracotomy patient. Next one is blood vessels and nerves encountered during thyroidectomy. Okay, right. So thyroidectomy, why do we have to do thyroidectomy? Thyroidectomy again, it is due to benign and malignant reasons. Benign are colloid nodule and multinodular goiter. Then cancerous conditions or malignant conditions are papillary thyroid carcinoma. Then other carcinomas are medullary carcinoma of thyroid, anaplastic carcinoma of thyroid, follicular carcinoma of thyroid. There are different carcinomas in thyroid which will lead or where the treatment is thyroidectomy. Okay, during thyroidectomy, what are the blood vessels and nerves? So we will first encounter what will know about blood vessels during the what is the incision given. Incision given here is 2 centimeters above to the subcostal notch. At what transverse incision is given from one sternocleidomastoid to other sternocleidomastoid. What is this incision name? Incision name is Cocker's incision. Right. Don't confuse with the Cocker's incision of cholecystectomy. Here also thyroid incision is also called as Cocker's incision. So first vein to encounter is anterior jugular vein. In subcutaneous, after you raise the flap from the skin and platysma muscle, below that you will find anterior jugular vein. That vein should be uh, cauterized or you should ligate that vein and then go deeper. After that, when you reach the thyroid level, the nerves which are vessels and nerves which you encounter. Vessel is first one is superior pole of the thyroid has superior thyroid artery and the nerve is external branch of superior laryngeal nerve. So yes, superior pole of thyroid has superior thyroid artery and external branch of superior laryngeal nerve. Then inferior pole of the thyroid has inferior thyroid artery and the nerve which encountered here is recurrent laryngeal nerve. So you should be or doctor should be aware of this vessels and nerves. So yeah, recurrent laryngeal nerve injury. If at all, if the surgeon injures recurrent laryngeal nerve, there is a high chance or the complication which follows this injury is hoarseness of voice. If bilateral, both sides recurrent laryngeal nerve are injured, then the patient will land up in closure of vocal cords. Vocal cords will not open up and then the patient will be unable to breathe. Then we need to perform an opening into the trachea, that is called as tracheostomy. These are the different complications when the nerves are injured. So the superior pole of thyroid will have superior thyroid artery and external branch of superior laryngeal nerve, and inferior pole of thyroid has inferior thyroid artery and recurrent laryngeal nerve. Middle part of the thyroid has middle thyroid vein Open. Yeah. Next one is complications of mastectomy. Next question is complications of mastectomy. Again, the same order you should follow. First one is infection. Sorry, first one is bleeding. Then followed, yes, as we do perform injury, opening a surgery onto the skin and the deeper tissues, there is always a chance of bleeding. Then infection. Second one is there will be post-operative pain. Fourth one is swelling. Swelling what? Seroma formation. There can be collection of fluid which will lead to seroma formation. Next one is edema. Yes, due to mastectomy, what do? We Yeah, in mastectomy, what do? We remove the nodes, which will lead to the formation of edema in the body. So you should be aware of these complications of mastectomy. The last question for today is deep vein thrombosis. Deep vein thrombosis is a condition that occurs when a blood clot is formed in deep veins of the body. It mainly affects the legs. What are the deep veins in the legs? The leg soleal veins and tibial veins are the deep veins which are present in the lower limb. So what happens in DVT is you'll have extreme the complication of DVT or the clinical feature is patient will have unilateral leg swelling, extreme redness and pain. These are the three things by which you should assess or you should think that it can be DVT. So the patient will have unilateral leg, whole lower limb swelling. Second is pain and third one is fever. The patient will have these three features. So yes, deep vein thrombosis mainly affects lower limbs. Why there is a chance of or a high risk where the patient will land up, or the etiology of deep vein thrombosis is any lower limb surgeries, any lower limb and pelvic surgeries will have the chance of DVT, because due to these surgeries the patient will not move for long standing days or for 7 to 8 days. When the patient is bedridden, so what happens is blood will get clot and this will lead to formation of thrombosis. So yes, these are the different things you need to be aware while writing an exam. So all my advice here is remember the side headings, remember the definitions, present them properly. Presentation is important. You keep the side headings and just if you fill in below the side headings, I hope you will get good marks. So it's all about presentation. Even though if you have subject and you don't know to present, it's highly difficult. And wherever necessary, you should draw diagrams and flowcharts. So that's all for today. Thank you. Is that okay?
Yes, sir. I'm ending the session now.
Yeah. Thank you.
Thank you.